I welcome you all for the post-lunch session titled Mystery of Sepsis, Identifying the Current Gaps and Available Solutions. For this session, the moderator is Dr. V. Balaji. Dr. V. Balaji completed his post-graduation in microbiology and obtained his PhD in basic science. He is currently a professor in clinical bacteriology at Christian Medical College, India. He previously served as the head of clinical microbiology at the same institution. He is Principal Investigator, Antimicrobial Resistance Surveillance and Research Network, ICMR. Some of the notable positions he held are Temporary Advisor for Emerging Bacterial Infectious Disease and Antimicrobial Resistance, Coordinator, National ECAS Program in India, Executive Member, Indian Association of Medical Microbiology, Executive Member, Hospital Infection Control Society of India, Editor-in-Chief for several prestigious journals, Member Task Force on Pneumococcal Disease Research Priorities and Antimicrobial Resistance. He has over 500 plus scientific publications in his name. Also past Editor-in-Chief Indian Journal of Medical Microbiology. Now I request Dr. V. Balaji to come on the dais.
Thank you, Dr. Seethal. So today, the session is going to be for the next 10 minutes. I am going to speak on sepsis, followed by me, Dr. Devjani will be talking. Then thereafter, for the next 40 minutes, 35 to 40 minutes, we will have a panel discussion. First, we will have a structured discussion, followed by open to the floor. So with that introduction, I will start my talk. In blood culture, practically what we see in the laboratory is two problems about the blood culture: false positives and false negatives. So false positives is mostly in our control because it's mostly contamination. And skin contamination, if you have a little understanding and little careful, to great extent that can be prevented. So there is no much concern about false positives. The only major problem with the blood culture is the false negatives. So where there won't be growth. So the reasons for the no growth is, it could be like this. The first thing to be blamed is iatrogenic, where you give antibiotics start ahead, then you will not get any positive results. So that seems to be up to 60%. Then fastidious and non-cultivable. Lot of fastidious are there, like a Borrelia, leptospirosis. You can mycoplasma, many things are there which you won't get it. And sometimes it's very difficult to cultivate. So this constitutes a small percentage. And of course, we don't want to talk much about the volume. It's a given that high volume always helps. Then lack of sensitivity due to low organism load. That is, typical example is Salmonella typhi, which is less than 1 or 2 colony forming units per ml. And the last one is, many centers, they continue to use only one bottle, including CMC Vellore, because people can't afford. Maybe in the cities and in the corporates, they will be much better off to pay. So we take a shortcut which is not advisable, or which is, actually it's not ethical also. It's important that you need to do 2 blood culture. I will tell the problem when you follow only with 1 blood culture. That is only aerobic, not including the anaerobic. So I will talk about the false negative blood culture, anaerobic blood culture bottle 1. And second important information which I would like to share is something new coming up very recently, that's called a decision support system. It's getting more and more attention, becoming very popular. It's getting trolled. So now I will talk about the anaerobic bottle usage. What is the advantage of using anaerobic bottle? Of course, you all know that anaerobic organisms will be picked up by this bottle. Aerobic bottle, definitely it won't pick up the organism. So what is the range? 0.5 to 11%. Not in all the centers, only in certain centers up to 11 it goes. Hardly we do see anaerobes nowadays because extensive use of carbapenem, which takes care of anaerobe, hardly seen. So that is one which discourages people to use anaerobic medium. But it's quietly, I should say, it's a misnomer. When you say anaerobic medium, strictly it's not only for anaerobic, it has got other advantages, which I would like to line list. So what the recent study shows about the anaerobic bottle is, look at this. When you do a routine blood culture from adult and children, the advantage of the anaerobic bottle is two things. Number one is it enhances the microorganism recovery. The microorganism recovery is much better than aerobic bottle. That is one. And second is it flags much faster. So definitely it has got two advantages. So I will show you some statistics. This is the recent publication where they have done close to 1,58,000 bottles collected in the year of 2019. And in that they picked up lot of Staph aureus in the anaerobic bottle compared to aerobic bottle. So this is one of the important pathogen. If you miss this Staph, I know for ID physicians it's a nightmare to treat Staph aureus. If it is endocarditis, if it is MRSA, even more difficult, challenging it is. So in a significant proportion, Staph aureus is missed by the aerobic bottle. And what is the percentage this study shows is, if they would have used only aerobic bottle, they would have not used anaerobic bottle, definitely less than 10%, means close to 10% of the Staph aureus they would have missed. And among E. coli, close to 14% they would have missed. So this is the new study tells, which has been published in ASM journal. And the time to positivity, again compared to aerobic bottles, especially for Staph aureus and for Proteus mirabilis, and in general all Enterobacteriaceae, it is quite high. So this is another study, again which tells that there were definitely 11% higher positive signal came from anaerobic compared to aerobic. And here this is the statistics between the aerobic and anaerobic. So 15% incremental increase in the anaerobic bottle with positive culture was seen. So this is another, predominantly it's a facultative anaerobe. So this class is very well picked up by the anaerobic bottle than aerobic bottle. Just to recall the memory, I will put all the facultative anaerobes. So you can see the list. This is the facultative anaerobes. You can say that, see, whatever the common organism which we isolate in the lab, almost everything is line listed in this slide, except Acinetobacter baumannii. Rest everything will be there, common. Almost 90%, this flags much faster than other thing. Interestingly, the last one, Candida glabrata, it's picked up only by the anaerobic bottle, but not by the aerobic bottle. That's another distinguished observation which this study group has seen. So this is the anaerobe and aerobe. Now, since there is a plenty of carbapenem use, it selects out carbapenem resistant, intrinsically resistant organism. Apart from carbapenem intrinsically resistant organism, Bacteroides fragilis is making a comeback, because higher percentage of carbapenem resistant Bacteroides fragilis is seen now. And first it's a re-emerging. Second point is it's a carbapenem resistant. Third point is, unlike other bacteria which produces carbapenemase enzyme, here it's not due to carbapenemase enzyme, it's here due to penicillin binding protein. So if you traditionally look for NDM, KPC, OXA48, IM, VIM, definitely you are not going to see that one. So Bacteroides fragilis is becoming a big problem, that's one. Clostridium, any abdominal, intra-abdominal infection, you are going to see more. And the Fusobacterium species are the other one. So that is the reason, since the incidence is going up, the BCID panel never had any of the anaerobe. The BCID panel 2 now has got an anaerobe included in the panel 2. And you can see the facultative anaerobe, all the alpha-hemolytic streptococci which causes bacterial endocarditis, you will be missing if you don't use anaerobic bottle. So this anaerobic bottle picks up the facultative anaerobes, especially infective endocarditis causing alpha-hemolytic colonies. So to summarize, when you use 2 bottle, increased blood volume and it increases the yield. And in the aerobic blood culture bottle, you have only 30 ml. Whereas in an anaerobic bottle, you have 40 ml. 10 ml extra, so it gives much more luxuriant growth to come up. And of course, anaerobic bottle will not have oxygen, otherwise it will have carbon dioxide and nitrogen. And Streptococci, enterobacterials, good yield is there, and faster detection of anaerobic condition. And Johns Hopkins has cited that enterobacterials and streptococci, close to 15 to 60% incremental increase has been flagged positive. So that is the advantage of using the anaerobic bottle. And Clabrata. So I just, out of curiosity, I went back and looked at the old literatures, what it says. And even in the old literature, it's quite clear. Anaerobic bottle flagged much faster and gave higher yield than the aerobic bottles. So traditionally, this was there for a long time. Somehow we have not made emphasized this. Now I move on to my second point, which I would like to emphasize, that is the decision support system. What is this decision support system is? Otherwise, we can call it as artificial intelligence, how it comes. So it's a guided sepsis management. And look at this one. This is one new tool called Prognosis Sepsis Immunoscore. This is the new tool in the market, which has been incorporated in almost all the Ivy League hospitals, Yale, Harvard, every hospital, Manchester, every Oxford, all the major hospitals have incorporated, and they are seeing much more success with this tool. I will little elaborate on this tool, and then I will talk about the antimicrobial susceptibility testing also, which is can be interpreted using the artificial intelligence. So, Prognosis Sepsis Immunoscore. So, it is a tool which is inbuilt with your clinical workstation. And whatever the clinical workstation has got the information related to the patient, close to 22 parameters that includes white blood cells, red blood cells, CRP, procalcitonin, other biomarkers. So all the information related to patients, especially this particular 22 parameters, if it is there, the more the parameter, the more predictive algorithm. It's a predictive algorithm. So it will tell you within how many hours the patient may require ICU admission, or it may predict the chances of high mortality. So this is what this predictive algorithm says. And this grades the sepsis. It grades as low, medium, high, and very high. So the score is something like this. If it is low, 0 score. If it is moderate, it is 1.9. High risk, it's close to 9. And if it is very high risk, it's 20%. So this is how it gives you alert. This is much better than human clinical judgment. However experienced they are, again the machine has said that they are little superior than the human judgment. So it was quite interesting. So beyond the mortality indicator, this tool helps to reduce the length of hospital stay, and it has decreased the intensive care admissions, and as well it has lowered the utilization of ventilation and vasopressors. Exactly what we expect. This tool assists you to reduce all this fact, including the mortality. So what's interesting, how this has been validated, how I can trust this. This is the question. Look at this. So this is the first time ever in the world FDA has scrutinized, validated it, and there is no scope for to endorse this tool. What they have done is, they have under the medical devices, they have used this predictive algorithm tool, and they have given an endorsement or validation and approved it. So this Prognosis Sepsis Immunoscore has received the FDA approval in July 2024, and this approval was granted through de novo pathway. So now it's almost standard of care in most of the hospitals in US. There is another tool which is being evaluated. This is called EPIC Sepsis Model Inpatient Predictive Analysis Tool. This is published in JAMA, and this gives you sensitivity specificity of almost 85%. It has seen great potential to reduce mortality, and definitely at the bottom I have written 44% reduction in the mortality they have seen. Still it's not crossed 95. Definitely they are improvising this tool, and it's going to be in the near future, this is going to be a standard of care. So now we have to compare between the tools and start using the tools. So it's no other excuse, it's going to be in. So now that's about the tool. Now I will tell what's happening in the antimicrobial susceptibility testing, what artificial intelligence can do. So if you keep the plate under a scanner, the scanner will predict growth is there or not. If growth is there, it will grade it. And when you compare the grading with the manually made MIC, it's almost 99% correlation is seen. It's really wonderful to see that there is no need for manual technical staff to do that one. And when they compared, it does much better than the technical staff. And similarly, to compare and match the genotypic and phenotypic comparison, again the artificial intelligence does much good work. And the two important publications which is available in the public domain is MIC prediction model with overall average accuracy of 95% with 1 to 2 tube dilution. Step for non-typhoidal salmonella has been achieved. And similarly for Klebsiella pneumonia, almost 92% has been observed. So this is another tool which is catching up. Probably in the next 2-3 years time, more and more improvised reports we will be getting, and this will also turn out to be a standard of care methodology. So with that I would like to end, and I want to call upon Devjani. So Devjani, she's a gold medalist for microbiology from Lady Hardinge Medical College with more than 12 years of work experience. So instead of going through all, most important I would like to say is a medical person on the technology front. So nothing like listening to her. We will listen to her now. Thank you, Devjani.
Hello. Thank you so much, sir, for laying the context of sepsis. So it is with great urgency and pride that we gather here today to talk about something as pressing in these times, that is sepsis, particularly in our context, in our setup, complicated by antimicrobial resistance. So sir has talked about two tools that enhance our capabilities in the front of sepsis, particularly the gold standard blood culture, and then the way forward, that is artificial intelligence. So what I'll talk about today is sepsis is a global challenge, and that's where the numbers, what the numbers say, that we have millions of people dying every 2.8 seconds, someone dies of sepsis. Sepsis is challenging, it doesn't spare even the children, and this is as per the latest Lancet. 1/3 of our sepsis mortality in India is due to antimicrobial resistance. So with those numbers, whenever there is AMR, it always complicates the sepsis scenario. This is one landmark study from All India Institute of Medical Sciences, Safdarjung, and one more tertiary care center in Delhi. So where they found out if there is AMR related, there is more of mortality, the case fatality rate is higher. But all is not doom and gloom. We have a tool that helps us fight against sepsis and antimicrobial resistance, that is blood culture. But what we'll talk about is how this fight is not fraught without challenges. It has its own set of hurdles, and that's where we did a survey where we reached out to several hospitals. It represents data from 145 plus hospitals and more than 230 participants. We reached out to microbiologists, to all the lab managers, to intensivists, to the frontline nursing teams, and we got insights from them. So as microbiologists, we bear witness to the complexity of blood culture testing. We know the bottlenecks in processing and analysis, and we all know the pain points. So let's hear it from India. Which are the main pain points of microbiologists? Of course, high contamination rates is one of their concerns, followed by it's a time-taking process, and of course staffing shortages. So now these are the numbers, but these are just not mere numbers. These are real-world issues that impact the gold standard test that we have against sepsis. So the collaboration, we can do much better on the collaboration front in terms of more interdisciplinary communication between the microbiologists and the clinical teams. This also requires a lot of homework on this. And next question that we asked is that what are the specific knowledge gaps? So not only are there technical challenges or operational challenges, there is a gap in the knowledge front, and the most important point that they found was in the clinical teams was that there was not proper specimen collection, and this is the fundamental concern whenever we are doing the pre-analytics, the blood culture. The collection is the most important. Our report is as good as the sample we collect. So this is one of the concerns that came up. Yes, so the microbiologists are doing this, doing something on this front. They are training, they are intensively training, and this shows a lot of commitment on the part of microbiologists that they have participated in training clinicians and nursing personnel. So it's all about, let's look at does that training translate into best practices. So we asked what is the blood culture set in their institute, and to our surprise, or despite the training, it is more of single bottles that they are getting. So one concerning statistic that we found was that 31.3% of the institutes, they get only one bottle. And we know that blood culture accuracy thrives on volume and diversity. So the right volume and the right set, that is the aerobic and anaerobic bottle, helps us determine whether it's a we would be able to clinch the diagnosis better. So that is missing. Particularly if you are not getting the etiology, that has a detrimental outcome on bloodstream identification, because we are not able to manage with the right kind of antimicrobials, and also not identify the source and do source eradication. So those are the challenges. So these are the statistics and the numbers. So the pathogen load in blood is really low, and that's why with enhanced volume or the right kind of volume, we would be able to get the right accuracy and the right sensitivity from the gold standard test. We also asked on the pre-analytics that how fast are they loading it in the equipment, and this is a positive trend. Most of the people said they are able to load it in the automated system within 2 hours, which is as per the guidelines. So what are the current limitations or barriers what the microbiologists feel? That educating the staff, whenever they educate the staff, there is attrition. So that adds to the complexity, workload, and of course not a 24/7 working lab. Blood culture diagnostics is a critical care parameter, it's a critical call out, and if it's not a 24/7 working lab, we are missing out on the positive impact that we can make on patients' lives. So those are the microbiologist side of the story. Now let's hear it from the clinicians. The clinicians are the first round of people who act on those blood culture results. So how often do they rely on blood culture diagnostics? So this is a resounding number. 92% of clinicians look for and they wait for blood culture results, but they have their own challenges. What are the challenges? They find blood culture reports taking lot of time. There is delayed reporting of results, and of course differentiating between colonizer and pathogen has always been a century-old question. Next, we talked about whether they have participated, because there are gaps, so whether they have participated in any CMEs, and the answer is encouragingly high. And let's look at, does that make them more familiar with the current guidelines? The answer is 56% said very familiar, but 44% require more of familiarity, and we can do a lot on that front as microbiologists. What improvements do they feel that can be done in the blood culture practices? So they want the implementation of current guidelines at the bedside, right volume, right set, more of CMEs, more of interdisciplinary collaboration, and of course collecting antibiotics, collecting blood culture prior to antibiotics. So those are the concerns. So we asked them what do they feel, what in their opinion is a blood culture set, and they said 88% of them said that it's an aerobic and anaerobic bottle. But then there is a misconception that anaerobic bottles only detect anaerobic organisms, so there is a gap there. Many of them feel that anaerobic bottles are dedicated for anaerobic infections, which is not the case, as Dr. Balaji mentioned. So communication, the communication link is strongly missing, and this is coming up in all the surveys that we reached out to every stakeholder. Who collects blood culture samples? So the nursing staff is the one who is shouldering that responsibility of blood culture collection. And have they seen, have they monitored or have they observed? So many of them have observed nurses collecting the sample, but sometimes incidentally. So what happens when we observe, we get a first hand experience on whether the process is being done right or not, and that gives a kind of we can do a feedback with a person who is actually collecting the sample whether they are doing it right or wrong. So next we asked on the post analytical aspect. So a blood culture being done, does it have an actionable information? Yes. So we asked them, do they get results of a gram stain after 10 p.m. or to 6 a.m. Those are the off hours, because that's a critical parameter that needs to be called out every time it flags positive, but it is only 68% times they don't get an answer in the off hours. So that's where 24/7 labs would be very helpful. So this is what CLSI says, a simple tool like gram stain, if it is reported 24/7, that can improve patient outcomes. So a simple tool like gram stain goes a long way in saving patients' lives. And we also asked them, do they get an interim report? So that's a positive trend. They get an interim report, which is a good thing. But what they want from the microbiologists is that they come from the bench to the bedside more often, and there is more of interdisciplinary collaboration. And finally, what do they advise? They want more of CMEs, more of quarterly meetings, and more of integration of diagnostic and antimicrobial stewardship. Quickly going to the unsung heroes, the nurses, our soldiers who collect those blood cultures. We asked them, how frequently do they perform blood culture collections? So many of them do it occasionally, 32.4% do it occasionally, but what guidelines have seen, and in fact there have been large scale studies also which have found out that regardless of the aseptic procedure or the aseptic disinfectant that we use, if it's a dedicated phlebotomy team that does the blood culture, it is always the best practice regardless of which disinfectant we use. Then there are several challenges in spite of that. So they have difficulty in locating the veins, and workload is always a pressure, but still they feel confident in their knowledge of blood culture, and they have been part of training, and that reflects in their knowledge of pre-analytics. However, some of them are still sending blood culture frozen and refrigerated, which is a wrong practice, and that's a training that needs to be done at their end. And what factors contribute to delays in transporting? So the bottle waits long enough because of communication delays or logistic issues. So out of this survey, what we found out that this is a clarion call for more collaboration. There are gaps in practices which need to be implemented. Communication needs to be strengthened, and that's where we can make the gold standard, again the gold standard, that's blood culture diagnostics. Thank you so much.
Move on to the panel discussion. So I'm delighted to invite Dr. Subhash Todi. I think he is the face of critical care medicine in India, and I should be very thankful for him traveling all the way with such a busy schedule and to be with us to answer our questions and spending value addition to our discussion today. And next I would like to invite Dr. Senthur Nambi, infectious disease specialist from Apollo Hospital, Chennai. Again, from his busy OPD schedule, he has come. I always see Dr. Senthur Nambi as the physician who treats all successive chief ministers in Tamil Nadu. Next, I would like to invite Dr. Maithili. I think she's a native of Pune. Please, ma'am, please come. I don't know. She's got a rich experience for 25 years in this locality, and it's nice to listen to her. So now we want to focus on three things. First, the challenges and the innovation which will improve the blood culture in day-to-day practice. So that's one area. And second area is, again, we want to recall and touch upon the, Devjani, sorry. And we want to touch upon culture negative, how we will manage culture negative blood cultures. So that's quite tricky, and physicians or even the interns keeps on checking the computer for any positive signals. In every ward rounds, they will be asking, is that positive? Because when the treatment with the empirical treatment, if it does well, it's fine. If the empirical treatment is not working, then definitely they will look for some cause so that management targeted therapy is given. So they will be after us. How do we manage this situation? You can have this. How do we manage in a culture negative situation? That's the second item we would like to discuss. Third one is, we would like to listen to the clinicians, intensivists, how they manage the sepsis at different situations, because it's quite complex to manage when there is no culture positive, or even if it is culture positive, multi-drug resistant, or there is a high risk comorbid conditions, how they manage. So these are all the three items which we would like to see. So I will like to start first with the intensivist, Dr. Todi. Sir, I would like you to detail how in the ICU you see the implementation barrier for the blood culture practice.
Thank you, Dr. Balaji. I think there are 5 barriers. First is the knowledge barrier. So the knowledge barrier is, we have discussed a lot about what to send, how to send, but the question is whom to send. I think that needs to be addressed as well. We don't want to go too extremes, don't want to send too many or too little, and that is where the first problem starts. And in ICU, anyone with an infection, with an organ dysfunction, sometimes we wait for patients to be too sick to send the blood culture. So they have to be in shock. So I think that we should not wait that too long. Anybody with an infection, with an organ dysfunction, we should have a blood culture. So I think that is where the sepsis definition is an organ dysfunction. So I think first is the knowledge barrier, whom to send the blood culture. Second is the organizational barrier. You mentioned about ICU. I was thinking, we had this problem I'm sure Senthur is also facing it. Most of our patients come through emergency department, right? And nowadays with a focus on early antibiotic, we can't wait for the patient to come to ICU. They have to get the first dose if they're diagnosing sepsis in the emergency. And we want the blood culture to be sent before the first antibiotic. So we started having lot of this contamination samples, because as you all know, emergency departments are busy and the quality control of blood culture drawing is not very good. And that is where our biggest dilemma is now. We can't wait for the patient to come to ICU to give the first antibiotic, and how to quality control the blood drawing in the emergency department. I think the organizational issue is very, very important. The third is, as has been mentioned, the collaborative and the communication issue. And the fourth barrier, I would say, is economic barriers, as has been mentioned, because sending 2 sets, 4 bottles, even in the big corporate hospitals, there are so many scheme patients now. People curtail in scheme patients, package patients, they don't send the whole set. So I think the economic barrier is there. And lastly, the psychological or the behavioral barrier. Patients, somebody with an anemia, for example, having a hemoglobin of 8, to draw 40 cc, there is a psychological barrier. Am I going to draw 40 cc's in somebody with a hemoglobin of 8? So there are these kind of barriers are there, and I think this can be overcome with proper training, education, discussions and things like that.
Sure. Thank you, sir. So next question, what I would like to ask Dr. Senthur Nambi is, for the past 1 decade, microbiologists are overwhelmed with infection prevention and control. And similarly, ID physicians are more overwhelmed, apart from infection prevention and control, about the antimicrobial stewardship. So in many situations, you have been taught one side, hit hard, hit fast, then give antibiotic within 1 hour, golden hour of sepsis. And many guidelines in many states, before referring, they tell first give antibiotics and refer the patient, because they should not be left out without antibiotics. Many guidelines, they says, from rural to district hospital to the tertiary care hospital, when they are shifted, they need to be given antibiotics. So it's like one way you teach something different and practice different. There is a huge mismatch is there. And there is an urgency of doing blood culture. In this situation, how do you see this antimicrobial stewardship working with the urgency of blood culture taking?
I think what you have asked is a very practical situation. So if you work in a tertiary care center, probably 80% of your patients have been referred from some other units. When they come from some other units, they're already exposed to antibiotics, may or may not have cultures done. So it becomes a very tricky call. So in our center, what we do as a routine is to get blood cultures done, irrespective of whether it has been done or not, all those things. And it's our practice to do 2 sets of blood culture. And again, we did find that there were some gaps in the emergency department with respect to the culture volume or the protocols, whatever it was done. So in our hospital, we have this sepsis pathway. So where just like the infection prevention and control, you monitor your device-associated infections. All our patients on a daily basis, we have a sepsis pathway where we say whether the IV antibiotic is pushed, have you done a blood culture prior to that push of that IV antibiotic? That is taken as a quality parameter by our organization. So that is what we do. And it is not something mandated by NABH or JCI, something like that, but we have kind of incorporated into our system. And then we do have our own contamination rates with respect to coagulase negative staff. And whenever we find it a little bit overshooting, then we do course correction in terms of personal training. So this sepsis pathway, every day the administration, the medical head or the operation head will ask how many patients with sepsis have come, what is that sepsis pathway, has it been fulfilled? So it is taken as a quality parameter, and it is not done at the end of the month in terms of what is being done. It is done on a daily basis, and then that is something that is kind of when you do that, the administrative backup is there, then there is a heightened awareness, okay, it should be done. But I don't think we have any control of what is being done in the other hospital. So whenever it comes to our center, we have a protocol of doing 2 sets. Having said that, for an outpatient with a community acquired fever, we don't do 2 sets. We end up doing only one set. Because I don't see a need for 2 sets as a routine. Generally, you're looking at salmonella, something like that, for which we end up doing 1 set. But all hospitalized patients, especially inpatients or ICU patients, where parenteral IV antibiotics are given, we recommend strongly to do blood culture 2 sets. That is what we do. And again, this anaerobic bottle, since you invoke Chief Minister, I am telling you, in 2009, when the sitting Chief Minister got admitted, he had a gram-negative in the blood plaques. Anaerobic bottle flagged Klebsiella first. That aerobic bottle actually flagged 8 hours later, actually. So I think we should do anaerobic bottle in addition to the aerobic bottle. So it's not 2 aerobic bottles. It is 1 aerobic plus anaerobic 1 set. Another set, definitely yes.
Yes, sure. Thank you. So I know definitely for day-to-day practice, continuously making sure all these parameters are, awareness is there and it's taken care. So I move on to the next question to Dr. Maithili. See, in my experience in the lab, what we see is whenever there is a new batch of interns come, they start in the February. So we have an orientation class. In the dummies, we teach them how to do a blood culture. In spite of that, we can expect for the next 2 months, maybe up to May, the contamination rates going up. Then it will settle down. So this is one annual features which we come across. And during the orientation, we repeatedly educate the students to make sure that they do very carefully. Because in our hospital, nurses are not allowed to do the blood culture. The doctor has to do the blood culture. So this is consistency. That is one thing which, and second one is sometimes occasional events also can be there. Once they've changed the disinfectant brand. So they got one cheaper one. Actually, the same product, they gave cheaper, they were happy. Actually, it's not weight by weight, it's by volume by weight. The concentration was less. it was not doing good, and we have seen consistently for some time contamination increasing. So these are all the certain things which we have experienced. I would like to ask Maithili, do you come across this quality practice consistently over the years? So I shared my experience even before you gave your
And
comments.
if I say yes, I would be lying, because it is not possible to have the same quality all throughout the year. Like, I come from a private corporate group of hospital, so we don't have interns, but our resident doctors do the blood cultures, and it is a continuous process of training them. The heads already know what to do. The critical care head knows what to do. The ID head knows what to do. But they are not going to collect the samples. So we have to hit at the ground staff, those who collect the samples. And the quality starts with pre-analytic. Like in any lab, we would have pre-analytic, analytic, as well as post-analytic pathways which are measured. So the quality will start with right collection of sample, the volume of sample, the sets which are collected, then the transport, like we saw the bottles were frozen, the bottles are stored in fridge, and if they are stored in fridge, then again the quality is going to go down. So these all things matter when it comes to quality. Very small things, we may feel they are insignificant, but they become very significant when it comes to the actual report. To give a very reliable blood culture report, it starts with all these things. Then the transport to the lab. You can't have the blood culture bottle lying in the ward for 8 hours and then it is coming to the lab. No, the blood culture bottle has to be transported to the lab. The lab has to be fast enough to load the bottle in the blood culture system if they are using automated continuous monitoring system. And again, the lab has to be fast enough to give the gram stain report of the system. Because here again, the quality starts from the collection to the lab. In analytic phase, it would be the volume is also important, because every ml of volume will increase the yield by 3%. So the volume is very important. And once it is in the lab, the monitoring system will be very important. The machine is beeping, but nobody is looking at the positive bottle. That again is going to hamper the quality of our report. So the fastness and promptness of a microbiology lab. I mean, since age-old thing, biochemistry and hemat were more prompt, microbiology was more a bit laid back, working from 10 to 5. Now that time is gone, microbiology works 24/7. You have to work 24/7. And then promptly conveying it to the clinician what is happening. Exactly. And these we maintain as quality. In our lab, we maintain this as quality indicators. The contamination rate, we have kept an acceptable rate of between 4 to 6%, because sometimes a single bottle comes and coagulase negative staphylococci are very difficult to explain why they have come. But if these indicators should not be maintained only for the lab. They have to be maintained ward-wise. It may be that ICU is very particular about these things. Everywhere the ICU is very particular. No problems there. But the moment you go to the ward, the contamination rate will increase. The ER contamination rate will increase. So ward-wise, if we maintain the contamination rate, then it is more easy to go back and train those people. Even the volume. Like volume is also one of our quality indicators. Every time a bottle comes in, now we are using Virtuo, so our human effort is lessened. But one has to look at the volume. So weighing the bottle was becoming difficult. So we had bottles marked and 3-4 bottles kept. That the moment a bottle comes, the technician has to compare with the marked bottle whether the volume is still there and then note it down. So that also became a quality indicator for us. So these small things help in a long way in giving us a more reliable report to the clinician.
Hello. Thank you, Doctor. Devjani, would you like to give a comment on how the accuracy of doing proper blood culture improves the outcome?
Absolutely, sir. Thank you so much for the question. So, if we want our blood culture to give us the best kind of diagnostic accuracy, we have to follow the bundle approach, which has to be the implementation of best practices at all phases of the lab workflow. So, pre-analytical, analytical, post-analytical. And one of the metric of blood culture success is that how well we are able to recover the microbes. And one of the indicators, the first important variable, as has already been mentioned, but cannot be overemphasized, is the fact that volume is the most important variable, because the pathogen load is very less, and to increase the sensitivity of our test, we need to collect the accurate volume, not less, not more. If it's an adult bottle, 10 ml means 10 ml, not more, not less. Then going on to as important as the volume is the timing of sample collection. So the Surviving Sepsis Campaign guidelines say that we prioritize collecting the blood culture before giving the antibiotics, or even if the antibiotics have been administered, we collect the blood culture before the next upcoming dose, so that the values, the MIC, the plasma levels are really less of the antimicrobial, and our chances of detecting the microbe are more. Then of course, aseptic collection. So we don't want false positivity. It is very important that we have the right collection technique. Of course, after that, the combination of bottles, the aerobic, anaerobic, again has already been mentioned, that is the right set has to be taken. It has to go into the incubator at the right time. The pre-incubation temperature has to be right. After that, when we are doing the analysis, combining the, reporting the gram stain at the right time, combining with rapid diagnostic tests, all of that bundle approach, and then integrating it into our clinical and our lab workflows, that would impact not only diagnostic accuracy, more improved accuracy, but it also goes a long way in saving lives, because it reduces unnecessary antimicrobials, treatment emergent adverse events, and length of stay. So all of that has been proven, and this is how we get a measurable impact by having implemented all those practices at the right place at the right time.
Sure, thank you. So before moving on to the culture negative blood culture management, I wish to make an important comment. We always blood culture think about the inpatient, and we talk all about, it's much more easy as an inpatient. You have the blood culture collecting kit, and you have the nurse bed, everything, infrastructure is there to help people are around. So it's good. But we are not at all thinking about the outpatient setting. And it was very, very meager blood culture is done in the outpatient setting. In outpatient setting means what I would wish to tell you is about the community acquired infections. Absolutely, we don't have any evidence of community infections, especially typhoid fever. Dr. Nibedita Gupta, the Director of Infectious Disease for ICMR, is around. She runs many number of meetings, many number of projects, investing so much just to collect and make sure, because typhoid is unique to the Indian subcontinent, where we see more number of cases, and it's not coming down, and it's going one level higher. Cephalosporin resistance has gone up everywhere, it's seen. Now carbapenemase resistant S. typhi is going up. So it's really throwing up a big challenge in the community acquired infection. So we have to slightly move away, means also think about the community infections. Also we need to do the blood culture, and the blood culture has to be followed strictly with all the parameters which needs to be followed has to be followed. Because in a community setting, drawing adequate blood, having a sterile set, having assistant to collect the blood, everything will be going to be a much more challenging than an inpatient. Now I move on and ask Dr. Todi to give comment on how you manage effectively on the culture negative patients, blood culture negative patients.
The blood culture negative patients, first of all, the reason for blood culture negativity, you have mentioned in your first slide, was prior use of antibiotics. In most of the guideline, it is the best practice statement. What is the evidence that if you give antibiotic and if you draw blood culture, if you draw blood culture after giving antibiotic, what is the evidence that the sensitivity goes down? So only couple of years back, this study was done where they gave an antibiotic, they drew blood culture before, and they drew blood culture 30 minutes and 120 minutes after giving antibiotic. It has come down by 50%, by 120. That's the only trial which has been done, and it has been published, the fabled trial. So I think yes, so the best practice statement is true, but it is by 50% only. So it is always worthwhile, even if a patient has received antibiotic, one should not say that the patient has received antibiotic, we should not be giving blood culture, drawing blood cultures. The second is, you mentioned about the false positive and the false negatives. There can be true negatives. in the sense that there can be a non-infectious cause as well of the patient's what is called sepsis-like syndrome. There are many sepsis mimics, many sepsis mimics in the ICU, and where the blood cultures will remain negative. So the literature on culture negative sepsis is very varied. They say that the commonest reason of culture negative sepsis is lower respiratory tract infection. It's very high in hepatobiliary, genitourinary, they have positive blood cultures. Pneumonia may not have that much of a positive blood culture. The morbidity and the mortality of positive and negative varies so much in the literature. Some literature says they are the same as culture positive, and some literature says it is worse in the culture negative cases. So I think the outcome is also variable. So the way we manage, if somebody who looks septic and has culture negative, the problem comes with the de-escalation. How do we de-escalate antibiotics? So most of these patients do not land up having de-escalation. There are certain guidelines that you can stop gram positives in these cases, continue with the gram negative. So those are the issues with the culture negative cases in the ICU.
Thank you, sir. So next question I would like to ask Dr. Senthur Nambi is, some few years back I was asked to talk about the culture negative, blood culture negative, and what is the outcome. At that time when I searched the literature, I found that if blood culture is positive, then it indicates overwhelming infection, and the mortality is, if not treated, then it's going to be higher. If it is culture negative, there is no overwhelming infection, so the mortality is less. I don't know. This is what at the time our understanding was there. Of recent time, I have not gone through the literature. In your practice, how do you see this? Because majority of the time you are going to see culture negatives than culture positive.
Community acquired bacterial infection, anything above the diaphragm is generally culture negative. So community acquired pneumonia, it's culture negative. Community acquired meningoencephalitis, generally your blood cultures are negative. Even your CSF culture yield is going to be, I'm saying the traditional thing. So these are two syndromes from the community. Anything below the diaphragm, as Dr. Todi already mentioned, hepatobiliary or urinary tract, it will be positive, or some tissue infections. Anything above the diaphragm from the community, it's going to be negative. So it doesn't mean that pneumococcal pneumonia will not behave as badly as something else. Hospital-acquired pneumonia is totally different. It's rare to have a culture negative situation in hospital-acquired pneumonia. Regarding the literature with respect to the outcomes between culture negative and culture positive, as Dr. Subhash Todi already pointed out, there are variable information. There was one recent meta-analysis which is published in Curious, which compiled around 23,000 patients with culture positive, culture negative, which ended up saying that the overall mortality does not differ much between culture positive, culture negative. The length of ICU stay, the need for ventilation, the need for renal replacement therapy doesn't differ much between culture positive and culture negative. But is it really true culture negative? Then in India, we need to look into other causes for sepsis. There is an infection, there is sepsis, but it's not a bacteria. So it's not prior exposure to antibiotics, it's not a pneumonia or meningitis. Perhaps they have a viral sepsis. It could be any of your respiratory viruses, it could be dengue, it could be chikungunya. Apart from that, you can have at times leptospirosis, rickettsial infections, scrub typhus. So it's very imperative for us to exclude all these things. And in any ICU, especially during the rains, you would have 20% of your patients, or even 1 in 4 of your patients may have these community acquired pathogens which presents with sepsis and multi-organ dysfunction, and they are traditionally culture negative. So it is very important to look into that aspect too.
Okay, sure. Thank you. I would like to make a comment for both of you what you have said, that the secondary sepsis due to urinary tract infection and intra-abdominal infections are much more than the lower respiratory infection. The reason is there is a leaky gut, and the commensal flora or the microbiome of the gut and the bladder are almost same. So what is there in the gut, 1/3 is there in the urinary tract. Nothing new addition is there in the urinary tract. So it has been very clearly now established that they have, we don't know how it happens, that even though there is no direct conduit is there, indirectly it's all there. So something access they call it as. So evidently it reflects as the secondary sepsis. Now I'm moving on to Dr. Maithili. We have seen there are definite guidance are there that for staph aureus, even though you have diagnosed, you have started the therapy, still you are asked to do one more. Then even same thing for Klebsiella, if there is flax positive, again you are requested to do one more, because you need to make sure clearance has occurred. After the clearance has occurred, from the day one is the therapy, then thereafter for 14 days you have to give. So where are all you will advise repeat blood culture for the positives already which you got, and where are all you will, in spite of being negative, you would like to repeat the test?
The negative ones, obviously it is more complex. Like culture negative will have its own causes. It might be a true negative, it might be a false negative. The false negative, the onus may be on the person who is collecting the sample, the onus may be on the person who is administering the antimicrobial, or the onus may be on the lab, or maybe a improper method of storing the bottles or processing the bottles. All labs may not have automation to process the bottles. So and then which culture bottle is being used. Everyone may not use an aerobic and anaerobic bottle, so there we may be losing some of the bacteria which grow in anaerobic bottles faster and give more early time to positivity. So in these cases, if the suspicion still holds true, I mean, we keep getting frantic calls and we can understand the disappointment in the clinician's voice. Is there anything? And we say, no, nothing. So again the call comes, is there anything? And we say, no, nothing. Then ID physician, I mean nothing against the IDs, ID physician will say, something is wrong, madam, in our processing. You have to look into this, something is going wrong somewhere. So these are the times we generally go in for, then we finally have to say, send one more sample please. That is it. And in positive cases, candidemia is one case where repeat cultures have to be done to see whether the candida is totally out of the system. I mean, that is one case we say, please send a repeat culture again. Like I said, there are some clinicians whom we don't have to tell this. They will keep insisting and they will send it. But there are many more. You are not only catering to a corporate hospital, ICU or anything. There are many, like our lab caters to outside people also. We have to keep advising them, please do send more cultures. Please do send, this is something which we need to see. Like in candidemia, definitely we ask for more cultures. In staph, you said, we ask for more culture in there. In staph also, sometimes you give a staph and the ICU may say, oh, we were never expecting this. From where did this come up? So these are the times when generally it's a dialogue between the clinician and the lab where we come to it that no, this needs repetition in spite of the cost. This is what we have to tell them.
We continue to see the breakthrough bacteremias. I have seen in one of the immunosuppressed individual where the correct targeted therapy is given, colistin susceptible Klebsiella pneumonia, in spite of giving colistin, 8 times the patient flagged positive at the interval of 4 days. So septicemia was continuing for chronic septicemia, and finally the patient died maybe 1 month of after struggle. So we do see different things. Now I would like to ask Devjani. We know that there are certain neutralizing substance are there in the blood culture bottle. So there is to neutralize specifically antifungal, antibacterial, it's there. Is there any, can you highlight on the difference of the neutralizing substance benefit in aerobic versus anaerobic, which is not the same, I learned?
Thank you, sir, for the question. So we know that false negativity can be high in sepsis, 40 to 60%, and most of the times it is due to prior antibiotics. Up to 63% of times we saw in the data sir showed. So modern blood culture systems are equipped with dealing with prior antibiotics, because if prior antimicrobials have already been administered, there can be artificial sterilization and false negative results. So the blood culture bottles, the automated systems, they are equipped with resins that bind and neutralize antimicrobials. So one of the landmark studies which was published in Journal of Clinical Microbiology, where they tested almost 1,000 patients where it flagged positive. The blood culture, the anaerobic bottle only flagged positive in 14%, and to their surprise, 2/3 of them were not obligate anaerobes but facultative anaerobes. So what is the reason? the facultative anaerobes did not flag in the aerobic bottle, and this is because of the differential neutralization capabilities of both the bottles. So the bacterial bottles, the aerobic ones and the anaerobic ones, they have some antimicrobials that are in common, they can neutralize, but the aerobic bottle is specifically equipped also to neutralize the antifungals. And the anaerobic bottle, the carbapenem neutralization is achieved. So those are the differentiating capabilities of both the bottles, and that is why again the combination of both the bottles not only improves the accuracy but also decreases the time to detection in the bottles.
Sure, thank you. Even though I have some questions for the panelist, but I would like to open up the floor for some important questions to the panelist. We are running out of time, so I want to give equal opportunity to the panel audience. Please feel free to ask. Please.
issues we get, the most of the septicemia patients, they also comes positive. But if anything,
very important is even little blood is enough. Way back 40 years back in our department, even a heel prick, one drop of blood is good enough to give flag positive, even when automation was not there. So any amount of blood is better in pediatrics, number one, because the density of the septicemia concentration in the blood is much higher in the children. As the blood volume is low, it reaches very fast multiplication. That's the reason. Second, you need to strictly follow the weight-based blood drawing in the pediatrics. So there is a table which says for what weight, how much of a blood is ideally required. So if you can follow, that is good. Second, use appropriate blood culture bottle because the volume should not get diluted. So these are all the, I feel, three important things which you need to follow. Yes, sir, please, sir.
So I'm not a clinician, so this might
Yes, sir,
be a
please,
foolish
sir.
question. So it's for false negative. So is it possible to add a bacteria, like suppose carbapenem resistant bacteria, if you add in a blood that you spread on the plate, if that does not grow, it will indicate that there you might be getting false negative. Is it done or is it possible to do that?
I can't get your question, sir.
Okay, the question is, so suppose there is a carbapenem resistant bacteria, or so you are looking for carbapenem sensitive bacteria in your blood sample. You spread on the plate, your blood suspension, but as the patient has taken carbapenem, so bacteria is not growing because the carbapenem antibiotic in the blood. What if you add any specific bacteria which is carbapenem resistant or sensitive in the blood to test whether you are getting right bacterial growth?
I don't think that anyone tried that. Do you know anything, sir? I think no intervention diagnostic anybody tried, sir, actually.
Okay, Ms.
Sure. That's a good thought. Yes, sir, please, sir.
I mean, what I wanted to comment is the pediatric blood culture bottles, so not only that they are optimized for smaller blood volumes, they're also optimized for specifically for pediatric pathogens and community acquired pathogens. So that's the reason these bottles should be used for pediatric. But one question maybe having, you might have faced this situation. There will be situations when we do not have pediatric bottles, the supply, there is some problem. The pediatrics people ask them, can we use the adult bottles in that situation?
Thank you, sir. So the important point, even I missed this, the pediatric bottle caters to the community acquired infections, streptococcus and all the community acquired infections. That's a very important point. Yes, sir, please, sir.
You know, you mentioned about that screening tool. You know, the Surviving Sepsis campaign says that there should be a screening. Now, the question is, that screening tool will tell us which patient is going to develop sepsis, but it won't change whether the patient is going to develop sepsis or not, right? It might predict future, but it's not going to change future, right? So, how does it help? It's like predicting weather, whether there is going to be rain or not. I can't change that, but I can take an umbrella with it, right? So, I think one has to, so I think this is more important in lesser, rather than ivory tower hospitals where people are vigilant, patients are being followed daily. It might be more useful in a less resource settings where patients are not so much observed. So there if I get a flag, that this patient might not be doing well, you can concentrate on that patient. For a high corporate hospital, people are being followed daily.
So especially in intensive care unit where continuous monitoring is there,
That's right.
Periodically you will be informed. So wherever people are stretched and you can't give prioritize,
Yes.
this mission will help you to give prioritize. High risk individuals. Dr. Senthur, you would like to make any comments? Especially I would like to have some comments on multi-drug resistant organism, how will you manage?
I think a couple of things. One thing is with respect to this blood culture volumes, people always say cost. Probably if you work in a corporate setup, always try to use this jargon called package. So if you say medi package, it means it contains a set of tests. What we have in a hospital is blood culture package. So blood culture package is 2 sets of blood culture. If I write 2 sets blood culture, it is build blood culture 1 set, blood culture 2 set. But if I write a blood culture package, it is 25% less than the individual cost put together. So because corporates like this term package, you can have a bronchoscopy package in which you have your Cramstein, bacterial culture, AFB, smear AFB culture, gene expert. So that's what we try doing in our hospital. And again, regarding madam, whatever she said, no, physicians get a little concerned. I think any physician or ID physician, when you manage a bacterial infection, he or she is as good as the microbiologist in the microbiology lab. So if the lab is not going to tell you, then you are in dark. That's the thing. And with respect to whatever carbapenem resistance, it all depends upon 2 situations: the setting in which where you practice and the kind of host that you manage. An immunocompetent or immunocompromised host, and is the patient is in sepsis, shock. These 2 things only will determine what antibiotic I'm going to use. Suppose if someone comes with a pyelonephritis from the community sitting in the OP, I'm going to give amoxiclav or cefixime, cotrimoxazole, pending cultures. The same pyelonephritis goes into the inpatient stable. I'll be using piperacillin tazobactam, ceftriaxone, sulbactam. That is what I use. The same pyelonephritis goes with an acute kidney injury, lands in the ICU, I would be giving carbapenems, imipenem, meropenem, ertapenem. The same pyelonephritis who lands in the ICU with renal injury and a multi-organ dysfunction, now I am thinking about meropenem plus or minus colistin, phosphomycin. So generally I believe it's not only the syndrome, but the clinical situation in which the patient presents, that actually determines what the choice of antibiotics. For community acquired pneumonia, we would give amoxiclav as an outpatient. Gets hospitalized, ceftriaxone. Little sicker, piperacillin tazobactam. Lands in the ICU, you will be ending up giving imipenem, meropenem. Pneumonia with septic shock, rule out viruses, then in addition to the imipenem, meropenem, you would be thinking of teicoplanin and linezolid. So the diagnosis is the same. Even your prediction of etiology is same, but you do not have the time window to wait and then. So the acuity which the patient presents also determines the choice. In fact, in practice actually that determines the choice rather than your diagnosis, all those things actually. Sicker patients, we kind of throw in more. When you throw in more, you're going to invite antimicrobial resistance. That's how it goes.
Thanks for your insights. Would you like to make any last comment, Dr. Maithili and Devjani?
In quality, it suddenly struck me that one of the most important parameters is the expired blood culture bottles. So they are lying in the ward, and at the same time, if the doctor is ordering a blood culture, nurse would just pick up any bottle which is lying in her drawer and take it up. So generally what we do is we have a lab round. The lab staff has to go every month and check every ward and see if any expired blood culture bottles are there and get them back. I'm sure for 1 month they must be working fine even after the expiry date. But sometimes they do go longer, and that is one more reason. The machines may not accept, so we'll come to know. But that can be one of the reasons of a negative blood culture too.
Sure, thank you. Devjani?
So just to close that, for sepsis, bloodstream infection diagnosis, our staple diagnostic test is blood culture, and that is the starting point of any other tests that we do, starting with any rapid innovative tests that are there, MALDI-TOF or the syndromic test. They all start with the bottle flagging positive. So if it is not done right, everything falls apart. So it is very important that the starting point is done right.
Yes, sir, please. Last question.
What advice you are going to give to the establishment where there are no automated blood cultures, almost around 50 to 60 maybe government, they don't have this system.
Sir, I was quite surprised by that question because what I was thinking, what we were reading over the last few weeks or months is now blood culture is somewhat, it's not going to be written and definitely it's going to be there, but even much more than blood culture, we are looking forward for directly picking up the organism from the uncultured blood. So that's where we are going, looking forward. But you are asking how to go back. I think in government, I think we have to step up our infrastructure, sir. Never ever we are going to improve. We can't say that it's as an excuse and get compromised. Yeah, please, sir.
I have
feel
visited
we need to
25,
gear up.
35 medical colleges in Maharashtra, and unfortunately, government medical college, and
colleges.
60-70% they don't have this facility. So my concern is that.
And of course, I totally agree with you.
To his question that we are telling everybody that we should have an anaerobic blood culture. The question is how many labs, what percentage of labs they have an anaerobic infrastructure to grow the organism on a plate and do identify and susceptibility testing. Not even 10% of the
10%.
labs. So this recommendation holds true only for those 10% who have an anaerobic infrastructure available.
But it's all the more I want to end this session with a comment that as a microbiologist and the clinician put together, I think we have to make sure that no need to continue to compromise on the quality of standard of care for a patient. So somewhere somebody has to start and the state has to declare that every hospital they need to have a mandatory blood culture system. Because when we have accreditation enforced, I think part of the accreditation even that needs to be emphasized. So last question, with that we will end up. She's very excited to ask question, please. Can you give mic, no? That's the last one.
Negative blood cultures, what about other biomarkers? Additional tests like procalcitonin may help in 90 to 90%.
We didn't have a scope of discussing about the biomarkers. There are many number of lactate, many numbers we should have discussed, but still the limitation of the time we kept it only for the blood culture. Thanks for reminding. So very useful insight from your practice you have shared. Thank you all, the audience, for putting up a very patient hearing. Thank you.
Thank you, sir.